Hi, this is Allison Buttenheim with Module 4 of Experimental Study Designs, the what, why, and how of randomization. Learning objectives for this module, we're going to understand why we randomize, and we're going to understand how to randomize in an experimental design. Okay, so what is randomization? That may sound like a really obvious question, but again, there's some sort of theory and theoretical frameworks underlying this. What we want to do is have a method that allocates our treatment or our control status to respondents at random or by chance. And that means a couple of different things. First of all, it means every individual or group that's being randomized to treatment or control has the same chance and an independent chance of being allocated to the treatment groups. It also should mean in reality that if your randomization scheme is truly randomized, you have no way to know in advance which group a unit of randomization will end up in. And that's a very practical definition that's really important. So why do we randomize? Again, this may seem like an obvious question, but we think about randomization providing the best causal evidence, the best way to do causal inference by creating a credible counterfactual. And what do we mean by counterfactual? So what do we really want to know when we do a randomized trial? We want to know if a treatment works. And in reality, the only way we can find out if that treatment works would be to observe the same group of people getting the treatment and at the same time not getting the treatment. And we don't happen to live in a universe where that's possible. So we have to come up with a counterfactual. We have to construct a counterfactual that is as close to that unobservable situation where we see the same group getting the treatment at the same time as we see the group not getting the treatment. We need to construct a counterfactual that's credible and is as close to that as possible. And random assignment is pretty great. It's pretty good, as good as you get, because you know that the only difference between the treatment group and the control group is the fact that you've randomly assigned them to one or the other. There are no other underlying differences that should be lurking there that might be correlated with your outcomes. And that's the second bullet point there. So if we do successfully randomize, we know that our exposed group and our unexposed group are similar on all attributes that might affect our exposure, our risk, the occurrence of disease. And what we don't want to do, we don't want there to be any hidden correlations or associations between our exposure status and any confounders that might also be associated with outcomes. And randomization, random assignment, does a really good job of that. Some other reasons why we randomize. It's very helpful if you want to mask exposure status or blind the trial. If there's a random underlying process that's easy to implement, then it's easier for, say, medical providers not to know if they're dealing with a treated or a control respondent. They also talk about establishing sort of good faith between investigators and the scientific community. If you've randomized and you can demonstrate you've done it successfully, the rest of the scientific community knows that you don't have any kind of bias or skin in the game where you're trying to kind of drive results one way or another. I think there's also an argument to be made for randomization also establishing good faith between investigators and respondent communities. Some people get nervous about the ethics of randomly allocating treatment to some groups or other groups and not. But in most situations, resources are scarce, treatments are scarce, and there's a transparency and a fairness and an equity to randomization that, in my experience, most communities really appreciate. It's, if they can stand there while you pull the white balls and the black balls out of a bag and see why one village is going to get a treatment and one village is not, that seems like a better way to do it than political intrigue or, investigator preference making that choice. So there are a couple ways you can actually accomplish this. There are published tables of random numbers, and there are protocols for finding a start number and then continuing and using the numbers in that random number table to allocate to treatment or control, and we'll go through an example of that. Of course, Excel will generate random numbers for you. That's how I assigned you all to your work groups, and it's also how I figure out each week which 8 or 9 people are being evaluated for class participation. And you can just, it's a good way to sort a list randomly, and Excel is happy to do that until the cows come home for you. And there are also envelope systems that basically take advantage of some previous random assignment where you are placing a yes or a no, or a treatment or a control, or a red or a white in a series of envelopes that are the investigator then uses, or the research coordinators, as respondents accrue into the study, or participants, to assign them to one group or another. What you don't want is a research coordinator or a clinician trying to sort of decide as a new participant enters a study which group they're in. There should be a system for establishing that very clearly that can also remain blinded if necessary. So let's talk about the random number table for a second. Here's an example from Katie Schmitz's breast cancer survivor study, and this is what she actually did for assignment. She opened a random number table, closed her eyes, waved her hand around, and put her finger down on a number. It was 4. And then she had decided ahead of time that she would move across the random number table to the right, and she listed the first 9 numbers that came up in the table. 4, 7, 7, 7, 0, 3, 8, 3, 4. And of course what a lot of people say is, wait, 7, 7, 7 doesn't sound very random. And it only doesn't sound random if you're trying to come up with a list of numbers that sounds random. It's actually completely fine that you got 7, 7, 7 there. Now, how do we turn that into random assignment to treatment or control? Well, Dr. Schmitz had established ahead of time that if the number came up between 0 and 4, that would be a treatment, and if the number came up between 5 and 9, it would be a control. So she had a list of her study IDs. She applied the same rule to every respondent. There was the realization in this column of the random number table, and you can see how each person was assigned to treatment or control based on the rule. Now, there's nothing that says you have to apply the same rule to every respondent. If you want to end up with different numbers in different groups, or if different respondents are entering the study in a different format or a different way, it's fine to come up with different rules, but to use the same list of random numbers. So this rule could have been 0 to 8 was treatment and just 9 was control, and that would end up with a different assignment. So some things that are not randomization or random assignment. You can't just do every other patient, A, B, A, B, A, B, and you can think about which rule that violates. You obviously don't want to say, oh, well, these kinds of patients I want to be in treatment A, and these kinds of patients I want to be in treatment B. That violates all sorts of assumptions about your experimental design. And if you're recruiting, say, from multiple sources, it isn't valid to say, oh, well, everyone I recruit from the Center City Clinic is going to be in my treatment, and everyone I recruit from my suburban clinic is going to be my control. Again, you can imagine all of the underlying characteristics that might differ between those two groups. So, what are some desirable properties of randomization methods? That people who implement studies all the time really need to have this down pat. You don't want to be making it up as you go along or screw it up in the middle. So here's some good guidelines. It has to be easy to implement for any of your research coordinators, any of your field staff. You actually want a system that's going to end up with a slight imbalance in sample sizes between treatments. That ends up being actually sort of a reassuring result. You don't want anybody involved in the study to be able to guess, oh, when Mr. Jones walks in the door, I bet he's going to end up in treatment because. And you also want it to be a very transparent system. When we do studies, often in developing countries, and there's going to be a village assignment, it's really nice to do it in front of everybody using, again, drawing marbles out of a bag, and everyone can see exactly what's happening. There are different types of randomization. There is just simple, where you're allocating individuals to treatments as they accrue into the study. If you need treatment and control groups to be sort of equal as you go, you can do block randomization, where you, within a block, are making sure they're equal numbers in each treatment arm as you go. That balances your study as you go along during recruitment. And you can also stratify and do block randomization. So if you want to do the younger people and the older people and then randomize within those two groups, that's fine, or more severe disease, less severe disease, and then block randomization within the stratification. A couple other things to remember. You don't always have to be randomly assigning treatment and control. There are other things you can randomly assign. So one is randomized phase-in, where everyone's getting the treatment, but you're randomly assigning start now versus start in 6 months or start in a year. And that's a good design where you know the treatment is going to be good and everybody wants it. You just want to get some people run through first to see how that affects them. And there's also randomized encouragement. This is good where random assignment to the treatment isn't feasible because anybody really has access to the treatment. But you can randomize who's encouraged to get the treatment. That might be through what kind of emails they get or mailings or what kind of conversation they have with a doctor. So everyone's got access to the treatment, but you've randomly assigned what kind of encouragement they get. So hopefully that's equipped you to do randomization, and we'll see you in Module 5.